Thank you very much, Deborah. It was actually a pleasure to hear, for us, the first official response from OGAC to the report. So it's certainly a good start for us for the rest of the day. Before I open the floor for questions, and please listen carefully as our options may have changed. Patrick Kelly is the director of the Board on Global Health, and he is not able to be here today. He is in a meeting in New York, but sends his regards to everyone and his best wishes for the event. I would like to open the floor for questions. There are mics on either side, and we will take emails from webcast viewers. When you go to the mic, please state your name and your affiliation, but we would ask, this is a plenary session, would like to focus the questions to the OGAC senior leadership and then the leadership of the committee. So if you could please keep your comments to a minimum and look forward to using the concurrent session structure this afternoon for longer comments and more intimate discussion. There are several committee members who are present in the audience. Out of that 20, Catherine Wetton, Jennifer Cates, if you'll please stand, Angelina Kakuza, and Mary Bassett. Please do not be surprised if questions are fielded to you as well during the moderated discussion. As Deborah mentioned, she has colleagues with her from OGAC and from USG implementing agencies. We're really thrilled about that level of participation, but please feel free to call upon those colleagues as well anytime during questions in this moderated session. So, not everyone at once, but if you would like to move to the sides, microphones on the left and the right. It is likely that we may take a few questions and batch them together, and we'll just say that we'll get in as many as we can in the session. And Bridget is going to give you some logistical information at the end of the session to talk about the concurrent session, so we'll leave just a little bit of time for that. Yes, ma'am.
Jill Gay, What Works for Women, and we do get PEPFAR funding. My question is around how you're conceiving of revising your gender strategies and objectives, particularly in regard to male involvement during prevention of vertical transmission. We're seeing cases in Uganda where it's mandated in order to access antenatal care to bring a your husband male partner. And so women are paying their drivers to stand in as their husbands. And also, given the recent guidance from PEPFAR on violence, the concern that, if a woman has a violent partner, how will that be addressed?
Thank you. Can we take one question from that side?
Okay. Hello, my name is Liana Mahmoudi, and I am currently a GW student, and I study DME, so this is very interesting to me. And I am with the WASH Advocates. So I have two questions. When I read part of the report, or the evaluation report, and it's very comprehensive, so thank you for your hard work on that. I have not gone through all of the pages, but I noticed that morbidity was not mentioned as frequently as mortality, obviously, as it is more difficult to measure, I suppose. And if you could talk about, as we're moving forward, there are going to be more people on ARVs. How do you measure the quality aspect of it? And then my second question is regarding to an AIDS-free generation and whether ARV resistance is going to be a major concern. And I'm asking this question in particular because in a lot of these countries, people don't have access to water, sanitation, and hygiene, so there are higher diarrheal rates, and does that lead to and that can lead to resistance. Is that a concern? And is that something we would that would be looked at in the future? Thank you.
Thank you. Why don't we start with these if you'd like to, Deborah, if you'd like to go back to anything you'd like to add about the revision of the gender strategies and particularly the focus on gender-based violence, and if you'd also like to continue into that with the questions about age-free generation and the morbidity measures.
Sure. I think it would be a distortion, I think, of our intent to require male partner involvement. I think the issues are complex enough in women accessing care and barriers to care that would not be, I think, a policy that one could stand behind. If that's going on, it's something we probably need to be in a conversation with. it's one thing to encourage involvement. We found that sometimes women are able to come back and stay in care if they've been able to bring their partner and their partner is supportive of the intervention. But that again, that is a process. That's a dialogue that happens sort of with the care provider serving the woman. So I would hope that we could get to the bottom and not have this be misinterpreted in any way as a mandate. Your question around sort of quality of care beyond just mortality drops, this is where I think we need to look at some of the quality measurement issues, quality of life, someone being able to return to work, an area where we clearly can see morbidity drops when we are looking at the integration of TB and HIV, which run together, and good data to show the ability to impact positively on both and return people to a state of good health. But I think you're asking a good question, and that is, how do we keep our eye on other things that will crop up with HIV? We've seen it in this country that over time, the risk for diabetes, the risk for heart disease, the other things will come along in our patients. So it is something that we need to be aware of and looking for, vigilant for. Your question on resistance I'll take, and then you may want to add to this. Resistance will be an important issue. One could expect that it will be an increasing concern in the future. To date, right now, we are working with the WHO around putting in a network, reinforcing a network of surveillance that will help us to identify and pick up resistance through a more systematic approach. It does exist in varying populations, quite low in many. We've been fortunate so far. I think it's a very different experience in this country and the West, but it will be something that we need to be watching.
Thank you.
I'll just respond on the resistance. Certainly, that is a risk, and it has been found in certain settings. I'm very pleased to hear there is going to be a more systematic approach with WHO to monitor resistance. Our committee tried to find information. In fact, it was one of the tasks set out for us by Congress, but it was rather difficult to find good generalized systematic information on resistance. There is some information coming from the university partners, the Track 1.0 partners, but we weren't able to access that other than what had been published. And so I think a systematic and open process of monitoring resistance, I think, is very important for the future.
Thank you. Yes, sir.
Yes, my name is John Osika, and I am from APT Associates. My question relates to the issue of attribution of results at country level when there are more than one partner working on HIV/AIDS, which you have mentioned in your report. Considering the expected political pressure from the funders to attribute their money to particular results, and the reality on the ground that may be very difficult considering the different partners on the ground, what do you advise in terms of reporting, which would satisfy the political arm and also the evidence on the ground? Thank you.
Thank you. Take a question over here, please.
Hi, thank you. My name is Alan from the Batten School at the University of Virginia. My question surrounds the cost effectiveness of various interventions that you guys have looked at, and what areas you think currently need to receive more funding that are, under your analysis, the most cost effective.
Thank you. And one more question on this side.
Hi, thank you very much for that report. My name is Rick Burzon. I'm with the National Institutes of Health. And I had a question about the whole issue of evaluation and dissemination of information. The whole field of implementation science is moving forward. And when I was at USAID supporting PEPFAR, we had a program evaluation subcommittee. And I know that Dr. Paul Bowie is here in the audience as well, who is head of M&E there and can perhaps comment on this. But I'm just curious to know how, because this is such a complex issue in terms of identifying metrics and working with a variety of other groups to reach consensus on how to measure things and how to evaluate programs so that the successes can be implemented, and so resources can be best targeted and evaluated. Have you given some thought, I'm sure you have, as to how you plan to move forward in this, since it's been going on for quite a long time and we've had lots of false starts in this area?
Thank you. Deborah, if you would like to start with the question about attribution of results at the country level with multiple partners, and then we can split up those other two and save knowledge management for the last response.
Certainly. Well, thank you. You've hit on a really important topic and area of work, and we were actually very appreciative of the IOM. I think understanding of this issue and looking at the importance of moving to a different way of looking at attribution of results. As there are more players and more partners in this field, it's no longer just PEPFAR. It's the Global Fund, and increasingly it's country resources itself. So it's a little bit hard if you're paying for the drugs and they're paying for the lab and somebody else is paying for the healthcare worker, to sort of say, to count this as your contribution. It is a dialogue that we're having. We need to have this dialogue with our congressional members and others as well. But in many ways, what the IOM has recommended is what we are also thinking is that altogether there is an outcome of the country. There are X many number of people who are on treatment because the system is there in place to support that treatment. And I think we need to start measuring ourselves not just by what we do, but our role in working with countries is to do that kind of support that allows them to keep people on treatment. So this is working with, within that we may contribute a certain amount of money that does a certain range of things, whether it's direct, indirect, but at the end of the day, what will matter is the country's number on treatment or the success of prevention, and we need to start looking more broadly at attribution.
So perhaps we could take the last two questions together. If I could summarize correctly, it was sort of discussing the complexities of metrics development with consensus and harmonization to be able to target resources to scale up successful programs, and of those programs that you determine to be successful, either in terms of efficiencies or effectiveness, are there areas that you all feel should receive more or different funding?
And on this one, I'm going to turn it over and pull in my colleagues who are breathing and using this every day in terms of both on the cost effectiveness and some of the work there. Dr. Amy Du Bois is leading that work for us, and Dr. Paul Bowie in terms of sort of the knowledge management issues, if you'd like to comment.
And if you'd like to just step up to the podium so that we can actually broadcast what you're saying.
I'm Amy Dubois. I'm one of the co-chairs of PEPFAR's Finance and Economics Work Group. And I mentioned that just to say that this is an area in terms of cost effectiveness and larger sort of financial and economic analysis, which is a real priority for PEPFAR. And the fact that we have that work group, which was set up in 2010 and has become increasingly active, should sort of speaks to that. In terms of cost effectiveness specifically, it is something that is a real focus and an increasing focus for PEPFAR in its implementation science portfolio. And a couple examples, there are specific cost effectiveness components to the several very large combination prevention trials that are currently being funded. Cost effectiveness is an important part of the overall concept of impact evaluation that we're trying to do more of in our countries in a very targeted manner. It's one of the key methodologies related to that. And then just looking at, with a very specific example down on the granular level, the data that have come out and that are available, certainly male circumcision is among the most cost-effective interventions that we currently have in our armamentarium, and that's reflected in the very strong emphasis PEPFAR has put on implementing that in its program. So I think we're kind of covering this on, sort of a larger policy level, within our portfolio, and then, in what we're actually trying to set up in our operational plans and what we're implementing.
Hi, good morning. Paul Bowie, Deputy Coordinator at OGAC for Strategic Information. So to get to Rick's question around the evaluations, we recognize, I think, and Rick knows quite well from his own history at AID, there has been a gap in our approach to evaluations that we have typically targeted the higher end, kind of more rigorous applications of methods. And there's an in-between category that has been kind of left to the countries and to the partners and the like. In conjunction basically with IOM recommendations, but as well as the Scientific Advisory Board and GIO, we're kind of revisiting the proposal we put forth a year and a half ago around the implementation science continuum, which actually ties all the pieces together under a single umbrella. And our efforts targeting not only kind of at the high end with prioritizing which research questions need to be addressed, both from headquarters but as well as at the country, but looking at the in-between category of evaluations, be they program evaluations, which would cover the process, the outcome, and the like, but to think more strategically, but also respecting the evaluation policies that exist at the agencies. AID has a policy, CDC has a policy, State Department has a policy, so trying to, under a single umbrella, tie those together with stipulations in terms of what are the expectations with regard to types of evaluations that should be done within different types of programs, because we can't implement this across the board in every program in every country. So it's trying to prioritize which are the key questions that need to be addressed, how to do that effectively, but also scientifically sound.
So Paul, not to put you or Amy or Deborah on the spot, but just in follow-up and to try to get to the heart of what I am curious about is, since it's not just us in the USG that will be doing these evaluations for our programs and to see how best our monies are being spent, but how do we work, or what's the process that we're going to be undertaking to work with countries themselves to transfer these methods to them so that they know how to do this for themselves? And I recall that we started that initiative when I was there, and I'm just curious to know how that's moving forward.
Sure, great.
Paul,
Yes.
before you answer, actually, I would respectfully ask that that be a conversation that gets continued in the concurrent session this afternoon. So it'll be KEC 109, and you and Amy are the discussants, and I think that that's a very nice example of something that's more of a continued conversation, and would like to move through the line to get a few more questions, please. Thank you. Sir?
Hi, Ted Hammett from Apt Associates. My question is about the, I guess for Deborah, the report indicates that the federal funding ban on needle and syringe programs is a challenging, confusing, and complicating factor, to say the least, in HIV prevention programming for people who use drugs. I'm wondering if PEPFAR is, or OGAC is going to be issuing revised guidance on HIV prevention for people who use drugs in light of the reinstitution of the funding ban in 2011. The previous guidance from 2010 authorizes the provision of needles and syringes by PEPFAR programs, which is no longer possible. And I believe many of the partners and programs in the countries are having difficulty navigating these waters. And I wonder if there's going to be revised guidance from PEPFAR on this issue.
Thank you. To the left? My left.
Thank you. Good morning. Steve Morrison from the Center for Strategic International Studies. First of all, to IOM, congratulations. This is really an extraordinary effort, and we're all going to benefit from this. And the comprehensiveness and the analytic quality and the affirmation of the achievements and the very candid discussion of the problems that remain, all extremely valuable. And just thank you and congratulations. And it's to Deborah, the administration, and OGAC's interaction and the quality of that dialogue is also really impressive. And so I'm quite encouraged by the report and by what we've heard here today. My question has to do with the really difficult challenge around transitions, because the report walks you up to a certain line. It says creating country ownership, shared responsibility are essential elements to long-term sustainability. That is a core proposition. It also says, wait a second, we have to be very realistic. We have to take a patient, realistic approach here and understand that transitions towards those goals are going to be much longer than what some of us might have hoped for. And in the midst of but it doesn't really say much. The report doesn't really go beyond that point. It sort of walks you up to the point where this is a political problem, this is a diplomatic problem, this is a financial problem. It's one where the U.S. has some leverage, but perhaps less than we thought we had. And yet this is a fundamentally important issue in the dialogue with all of our partner countries, and even more important, front and center issue with a Congress that is going to be imposing budget cuts, likely, as the sequester comes into force and as other matters, not just for these programs, but in the broad sense of our budgetary turbulence and the like. So can folks from the IOM and from OGAC say anything more, look beyond, say anything more than we have a problem, Houston, and that problem looks out and it's fundamentally a political, diplomatic. Can we say anything more about how we're going to address that problem? Because that seems to be what lies on the horizon as the central major motivating challenge for PEPFAR going into the future. And you clearly delineate the nature of the problem without saying a whole lot about what to do about it. Thank you.
Thank you. One more question, please.
Hi, Sharon Stash from the Center for Strategic and International Studies also. Also looking forward and focusing a bit on PEPFAR transition. Clearly, transition is more than a shift to a technical assistance model. It also involves major reductions in funding, and in some countries, large dollar amounts, like in South Africa, where it's about a $200 million decrease in funding. And in smaller countries, maybe a lesser amount of dollars, but a large proportion of the overall budgets. Here, I wanted to talk about looking forward and saying, in the process of undertaking these complex and difficult transitions, how will we know when things aren't going well? What's the canary in the coal mine? What do we monitor for signs of slippage? What plans do we have, tentative plans for contingencies? A related question there is tuberculosis. TB, HIV co-infection, because the IOM report, again, is fairly thin on the TB component, I think perhaps reflecting the state of play a couple of years ago in TB HIV co-infection for PEPFAR. But here's a situation where, again, we have a legitimate canary in a coal mine in terms of the massive increases in TB infections throughout the HIV/AIDS epidemic, but also the more alarming increases in MDR and XDR TB right now. So what will be the focus on TB, HIV as PEPFAR transitions?
Thank you. Why don't we start with the initial question? Are there any plans to revise guidance on HIV prevention for those who use drugs with the reinstatement of the federal ban on syringe exchange?
Well, thank you for your question. It's one that is a critical one and a difficult one. As you know, the guidance that was put out had a range of interventions to reduce risks to people who inject drugs, and all of those, with the exception of the ability to take action directly on needle and syringe exchange, are things that we need to go forward with as much as we possibly can. So we have had to put out notice to the countries that we're looking to program resources for needle and syringe exchange, and be clear that that is something that we are not allowed to fund since that guidance has gone out, that prohibition. We haven't really talked about putting out a whole new guidance, because I think the guidance in itself is still a strong and robust one. And I think what we have instructed and talked through with our country programs is that intervention is not the most expensive intervention. That's where we need to be actually saying, who else can cover this? This is important. We need to champion it. We need to still speak to the value of that intervention, even though that's not something that we can directly support. But I think, and often, as you know well, countries where this is a problem don't like to think about perhaps investing in needles and syringes. So I think we have a job to do in terms of our public health messaging, that this is important and it will save lives. But we haven't thought of putting a whole new guidance out at this point. It's mostly countries like Mozambique and and Tanzania, not Mozambique, Tanzania as an example, Kenya going forward, extraordinary programming. And that's what we want to encourage.
Thank you. I'd like to invite both Deborah and Bob, if you would like to respond to, I'm going to combine the questions in terms of transitioning for sustainability, and then perhaps the focus on TB, HIV co-infection could be separate. But the description has been that the transitioning is a political and diplomatic problem. There's this pragmatic overlay of the sensitivity of time needed for transition. And with a shifting in the TA model, there may be decreases in funding, either absolute or proportional budgets, depending on the size of the country. So one of the questions is, can there be any more said up than going up to the point to say we have a problem, Houston? And what are the metrics or measures or contingency planning or the milestones? What are the things that are being paid attention to know when things are not going well, and conversely, when things are going well?
Well, I think that we wish that we never had come up with the word transition before. We are moving to sustainability and sustainable program because transition seems to have this effect on people of an immediate freeze and concern. And that is not helpful. I think that Steve is right. There are many sides of this dialogue with countries. At the end of the day, I think Ambassador Gooseby is very clear. We are still about saving lives and maintaining results. Yes, the resources are tight. There are other countries that have a growing need, but which we have not attended to because we've been putting a lot, perhaps here. The whole process of bringing government into this different relationship of services is one that takes methodical planning and dialogue about what the costs are. What are we paying for now? What would they need to consider picking up? I think we've had the benefit of having the CSIS team in South Africa looking again at the magnitude of work that's involved. Facility by facility, you need to be sure patients are not falling off of care, and your question is an important one. How will we know? What are the indicators that we put in place to be sure that we're responsible in this? The message is clear that South Africa has been willing to step forward and is able to pay more and is paying a great deal more for their own care and treatment now because they can and because they're willing to. So the transition there is a unique one, I think, of a willingness and an engagement, and it's just how do you do it carefully and how do you do it well. It's different in Botswana, it's different in Namibia, and other countries. That isn't a dialogue that we can really have for quite some time. It is important, though, to look at the whole panoply of resources that are available when you're looking at HIV and TB specifically as well. The Global Fund is a big player here, so are we using our resources combined as well as possible? First question. Before you're talking about drops, we need to look at how we're using our available resources. Countries are increasingly able to step up. The AU now has a platform. The African Union has a platform of shared responsibility. This is a dialogue that's been percolating now for a couple of years. I think when Global Fund Round 11 didn't come through, it was a shock to everybody's system. Like, what do we do if those resources aren't here anymore? So we're at this moment now where the dialogue is a different dialogue. We are committed to not doing harm. At the same time, you do use your diplomatic channels and your technical channels to try and increase and expand coverage and make sure the systems are strong enough to hold it.
Deborah gave a very complete answer, so I'll only add a couple very brief comments. What was remarkable to us when we visited countries was the extent to which countries, the nationals in those countries, felt they had country ownership. They had leadership now. What they don't always have is the finances, the resources to enact that. And I think the reality is some countries will be able to take over responsibility from a financial standpoint as well as the overall leadership, and some will not. I think that so the issue is there will be need for external resources in many of the countries that that are most affected by this epidemic. And where that comes from, national resources or international resources, I think is part of this debate. I think the reality is that this this effort to move toward the sustainable response came really rather late in this even 5-year phase of PEPFAR, and therefore for our committee it was not possible to really look at success stories or factors that helped to determine that faster or slower movement. I think now it's going to be very important to really have the information, the evidence on what are the factors that really help and enable countries to move forward. And in regard to things going well or badly, I think this goes back to, again, the need for good information systems for quality of care, for coverage, for comorbidity such as TB. I mean, this is just an essential element of knowing for the country what is going well or perhaps, unfortunately, not going well.
Thank you. And we'd like to remind people, take a look at their agendas. Hopefully we can continue this sustainability discussion in the session at 2:45. Perhaps we'll come up with a synonym for transition out of that session. But also to the care and treatment breakout that'll happen in KEC 109, and hopefully there'll be a much more in-depth discussion about TB and HIV co-infection, because I'd really like to get through the line, and because I recognize one of our fabulous staff people back there, I know she has questions from the webcast. So if we can, which side did I stop on? So if we'll go to my right, and then we'll take a series of questions, and then we'll see how quickly we can rapid fire answer through them.
Thank you very much. My name is Orhan Marina. I work for Catholic Relief Services. I'm a health system strengthening advisor. Together with the consortium members, we've been part of Track 1 programming since early 2004. We went through the scale-up phase, transition phase. And one of the things we noticed, and as also alluded in the report, was the issue of not seeing things with the lens of health system strengthening at the initial stages. Although we did a lot of health system strengthening, not only CRS and consortium members, the Easy Relief program, but other Track 1 partners too. My question is, was there any focus on evaluating the capacity and performance of the health system at this moment, or any recommendation about doing that in the very near future for the sake of monitoring the capacity and performance of health systems in these countries continuously in the future?
Thank you. To my left?
I'm Ann Lyon, and I'm the Director of the Health Financing and Governance Project that USAID funds and former Director of Health Systems 2020, so that shapes where I'm coming from. And I'm pleased to see all these questions around sustainability, financial sustainability, and system strengthening. I want to echo my colleagues in congratulating you on an incredibly in-depth and detailed report, and no report is ever complete. So my question is not at all critical. It's around that next level of completion. As we look at moving towards sustainability, specifically financial sustainability, obviously we're looking at donor funding trends. We're looking at how to use our funding much more efficiently, and we're also looking at increasing domestic financing. And when we look in our report, the section on domestic financing, I have to say, is incomplete. And so what I'd like, my question is, how can we go forward and make sure that you have the data that is out there? We've done, USG has funded, USAID has funded dozens of health systems assessments and HIV sustainability analyses and national health account information and NASA's, and even how to combine NASA's with NHA's and sustainability analysis. There's a lot out there that in the one paragraph saying that you couldn't find the information, it's there. So I'd like to hear how we can help you get it.
Thank you. I was just giving a warning to one of the committee members in the audience. Next question.
Hi, my name is Daniel Wolf from the Open Society Foundations, and we work primarily in countries where HIV is concentrated among criminalized populations, and where also the Global Fund new funding model is likely to constrict or withdraw funding, particularly in middle-income countries in former Soviet Union and Asia. So my question puts a slightly finer point on Steve's. about transition. The idea of local country ownership and sustainability is not reassuring to those who find that local policies already divert large numbers of people from treatment to detention centers and prisons. And I'm curious how negotiations around the partnership framework and the sort of the move to country ownership can be used to ensure that protections of due process or reductions of police harassment and other structural factors that impact HIV treatment and prevention can be shored up and safeguarded. Thanks.
Thank you. Lee.
I have one question from our webcast audience. This is from Adana Chukwuma from the Global Health Corps, who asks, in making this transition to country ownership, what plans does PEPFAR have to strengthen the internal capacity of countries to manage these programs collaboratively, especially considering that nonprofit organizations play an important role in these programs?
Thank you. And I've always wanted to say this because I love the movie, Mr. Anderson. Do you have a question?
I'm Todd Anderson. I'm from the GAO. Just wanted to give a quick thanks to the IOM, to the committee, and to the study group for the review and for the opportunity to touch base over the course of your work and as we've done our work over the years as well. Also thanks to OGAC and to PEPFAR for the opportunity to hear about the steps that you plan to take in response to the IOM evaluation. There's some synergies between the IOM evaluation and some of our work as well, so we're encouraged to hear about the plans, the evaluation plans, for example, and some of the dissemination methods that you're considering. As IOM has acknowledged in its evaluation, and OGAC has stressed, PEPFAR operates in this very dynamic environment. We've tried to acknowledge that in our work, especially the most recent round of work that we've been doing. Of course, that dynamic environment extends to DC and the political environment here. So the question I have for you all is, what would you see as some of the challenges and opportunities as the current authorization period that expires this year and PEPFAR enters into its third 5-year phase?
Thank you. Let's see how we'll sort of group the health systems questions together, and I think perhaps we'll start with the question related to the intersection of vulnerable populations and local sustainability and ownership, and the concerns by some who work with populations that behaviors and their identities are often criminalized. How or what can be done to safeguard the protections of these individuals as they continue to try to seek services in a transition where a response is more managed or driven and decisions are more made in terms of local capacity. We could start there.
I think that, there are some particularly concerning places where we have a small presence, but we've had a presence that has tried to work on some of these policy issues, particularly of people who inject drugs among the most vulnerable, and also other those MSM who are at risk. It's a very difficult thing to work in a country where the country's policies are against it. That said, I think the work we've always had to do is to make the public health case of why this is important. You need to relate it to incidents. You need to relate it to new infections. How much you can force as an external donor, as an external partner. You can't always get done what you would like to get done. I think you need to keep being the voice, though. And looking at what's happening in Central Asia and Russia, some of the stands, it's frightening when you look at the UNAIDS report. This is where the new infections are. I think we need to keep doing our best as public health people to raise that alarm and also profile what does make the difference, and hope that it takes root. We have seen the value and the importance of funding civil society and community in countries like that, where the ability to get services to people in some way, shape, or form is often through the community. And those investments are important ones. I think we have yet to see what's going to happen with the Global Fund in this arena. under their new funding model, but also I think not all the decisions about how the funding channels are going to work have been made. So it is an open and active discussion that we need to be having.
Okay. Thank you. If we can maybe move up another level in terms of another key stakeholder in terms of collaborative management of as country ownership, or the programs are shifting to more country ownership, including the role and service of non-governmental organizations, and if there's something that you all would like to comment about the role of civil society and NGOs.
Absolutely. We have a lot to say about that. I think, the idea of country ownership is not just government ownership, and the dialogue that needs to be had and that we do have in countries is this is a much broader conversation that needs to include both stakeholders and well as those the groups that are providing the care. Now they are the system. Particularly, you mentioned CRS, but the faith-based network of services is often sort of a lot of the fabric of what's actually delivering care, particularly out in the rural areas. There was just a meeting several weeks ago in Zambia of the Christian health associations from 12 countries. And in this discussion of sort of their willingness to step forward, to look at PMTCT, to figure out how to bring their networks in, really embracing the challenge, was an extraordinary time, and there were government leaders there as well as these health associations. So particularly, I think we need to, as PEPFAR, obviously be making the case that who are the players, what is the fabric that's in the country. They are the arms and legs of the government in many ways in terms of the public health system actually working. So I would say that it's certainly been our experience in PEPFAR. Not everything transitions to, I think we've been looking at how to increasingly use local organizations, indigenous organizations. Not all of those are government organizations, but the movement of care into systems that are in the country and will stay in the country is a critical one. So we need to do our job in the partnership framework discussions to increasingly also call upon and ask to have civil society and organizations represented and included in those dialogues.
Thank you. I think that we'll actually try to split a response, one from OGAC and one from the committee on these last two questions. And then I'm going to ask to turn it over to Bridget Kelly, who will give us some highlights of this discussion for us to sort of keep in mind and carry some themes into our concurrent sessions in the afternoon after lunch. And I hope that you all can stay and participate in those sessions. We're really looking forward to them. So, Jen, would you like to give a response in terms of the question? And we can continue that particularly in the sustainability session. But if you'd like to give a quick response to how can we really sort of generate more complete information in terms of domestic spending? Why don't you come on up to the, and while you're coming up to the podium, I'll just warn that the last question is going to be what do you anticipate in the next 5 years phase in terms of the dynamic USG environment, so you all can be thinking about that. Thank you, Jen.
So I'm Jen Cates. I was a committee member. The question was about domestic financing, and the committee, our goal was to collect as much data as we could on the external donor funding environment and domestic financing by countries. And we were well aware of the national health accounts. We were well aware of the great work that UNAIDS has done working with countries to track their own funding. But what we felt as a committee, there wasn't an apples to apples comparison that we could use at this time to allow us to make the kind of analysis, do the kind of analytic work we wanted to, even though there were some countries that had that information, not all did. So we couldn't look across and really be confident that we can make the estimates we wanted. And also, in countries themselves, we found several government responders who actually weren't aware of what both their governments were providing to HIV as well as what they were getting externally. And as someone who works on this issue domestically, I'm not saying that's unique to other countries. I mean, I think it's really a challenging thing. So there's a lot of promising efforts, but it's definitely going forward will be really critical. And just to pick up on something someone else said, what would be the next phase of this kind of work if we were to do it more, I think it would be on measuring a country ownership and what it means for sustainability. We spent a whole chapter on that, but that really was where I think we had to end, and it's really the next phase for looking at the program. Thanks.
Thank you. So the last question from Mr. Anderson is the anticipation of the next 5-year phase in terms of the dynamic USG environment. Any predictions, anything you'd like to share? And if you could give us sort of a quick response to that, and then we'll turn it over to Bridget.
Certainly. Well, the good news is that the PEPFAR it lives in the foreign it lives in the foreign assistance law, and we are embedded in statute. What does end this year, the end of this fiscal year, is a particular budget level authorization. But the program, as designed and as laid out already, would be able to continue forward at the will of the appropriators in Congress to continue the services. So I think that will be decided somewhere else, not by us. Our job is to keep the program going and to keep refining and improving it. And I would say that the blueprint really is, the PEPFAR blueprint is the vision of where we think it needs to go. I think in terms of high impact, in terms of working in a new way with countries and partners, Global Fund, I think the attention to the breadth of what country ownership actually means, and our role in supporting countries and having those capacities to take on those roles and responsibilities around planning and budgeting and designing the most effective program that will respond to their needs. That's our work to do in partnership. So the blueprint really is that vision. It's a lot of what we are doing and calling us to do more and different things with a broader set of partners. But I don't think I can improve on the blueprint.
Thank you. So thank you all for your very thoughtful comments and questions. We hope it continues throughout the day. I'd like to turn it over to my colleague, Bridget Kelly.
So after having to talk about the next 5 years, I'm only responsible for talking about the next 5 hours. So that's kind of a relief. I'm just going to say a little bit about the afternoon in terms of what to expect. I'll say a little bit about content and then also a little bit about logistics. And Maggie is going to put up the last slide in Bob's presentation, which just will put you in really big letters the same information that's on your agenda. Maybe one of the first pieces of information is that the entire report is available online. So if you haven't already had a chance to go check it out, the website is there. The report is available not only as an entire PDF, but also by chapter. So if there's a particular topic that you're interested in, you can start with that and then take the rest in small bites. Or maybe they're medium-sized bites, even the chapters aren't short. And the chapters also, there's an attempt to try to do a lot of cross-referencing. So you may find when you read one chapter that you are then required to go find another in order to really cover the ground. In addition to that, if you haven't already picked up a packet, we do encourage you to pick up a packet that's outside on the table, which contains the main messages for each of the chapters. And that is really going to help in terms of giving you what you need to frame the conversations this afternoon. So those are 2 information gathering suggestions for you. Just reflecting a little bit on the session so far, it's been a really nice opportunity to reflect on the remarkable achievements of PEPFAR. That's kind of the shortest way to say it, both in terms of what the committee found in its report and then also hearing from Deborah and from the other staff as well. So that is kind of a first and foremost takeaway, as always. But it's also been an opportunity to identify some of the challenges that remain. And this afternoon, we're really hoping will be a chance to look at how the findings in the report intersect with what's going forward in PEPFAR already. And there is a lot of alignment as PEPFAR reflected on some of the same information that the committee was reflecting on in the same period of time. So that's good to see. And the hope is that the conversations and moving forward is going to be moving into I almost said transitioning, moving into a more in-depth and really operational discussion. And I think that's the level at which within this broad alignment, there can be good opportunities for the report to help support and refine what PEPFAR is thinking of doing, and think about that. So that's part of the goal of this afternoon, is to really get into things at that depth. And we had a nice opportunity in the questions to already touch on a lot of things to spark the conversation. So we had some questions in the areas of gender and prevention and care and treatment, all of the service areas, and of course a lot of discussion about sustainability, about the opportunities in moving towards country-led approaches to sustainability, but some of the concerns that come with it, ranging from what's going to happen to the quality of services to what's going to happen to some of the populations that might potentially be at increased risk during that transition. So I think that there's a breakout on sustainability, but I'm imagining that will be a topic that comes up in other sessions as well. So I anticipate that will be a thread. Related to those questions, I think, as the core challenge for the future, were some of the discussion about the health system strengthening and the capacity building, and how that is going to feed into successfully moving in that direction. And then the questions about, what we termed knowledge management in that chapter, the questions about what's happening with evaluation, and how that's going to evolve. And that's at every level, really. It's thinking about the programs, evaluating the programs, knowing what's most effective and what's most cost effective, but also how to evaluate what's happening at this big picture level. How are we going to know whether the activities that PEPFAR is undertaking are successfully contributing to a more sustainable approach, but also in the countries themselves, what's happening to the programs and the services that happen. So those are, I think, other topics that I anticipate will come up in more than one session. We have a really inspiring group of discussants that we've invited to come and just try to spark the conversation today. But that inspiring group of discussants is much more enriched by all of you who have come as well. And just to set your expectations for the afternoon, we really have encouraged the people that we've invited to keep their prepared comments brief, because we really want it to start to be a conversation. And we want those of you who have joined, who might not be named on the agenda, but are nonetheless a really important part of the conversation this afternoon. So we've tried to structure the sessions that way. So we have members of the committee as well in the sessions, and we also have staff who worked in depth in the different topic areas, so they're familiar with the nitty-gritty of what's actually in the report chapter, so they'll be there helping to moderate and participate in the discussion as well. The other role that the staff will help with is helping you find where you need to go. So the staff are mostly in the back. If you guys want to stand up real quick, we can make sure that people see who you are. So this is our fabulous staff team.
What's left of our fabulous
Livia, Kristen, Kate, Maggie, Cece, and Lee. We have a former staff member as well, Mila, there she is, who has since left the project to go to graduate school, but not so many months ago that she wasn't very involved in this whole process. So we really appreciate all their efforts in the project as a whole. That's been said before, but they will also be around if you need help finding something or if you need anything. So just want to make sure you know who they are. Lee and Maggie were particularly instrumental in putting this event together today, so we really appreciate that. The time, as you can see, we're starting back up again at 1 o'clock. The rooms are up there. We'll leave that up, so if you're not sure where you're going, you can always step back into Keck 100, which is this room. The sessions happening in this room will be webcast, so those of you who are participating with us remotely will have breakout sessions, and we will still be taking questions. And then we have a break between each of the breakout sessions where we will have a few small snacks and refreshments here, a little bit of caffeine if you need that to get you through the second session. And we'll reconvene at the end of the day. And what we're going to do at that final session is have someone from each of the breakouts just give a little bit of a recap of the highlights, so that if you didn't get to go to a session, you can at least hear some of the main things that came out of it. Our hope there is that we'll have a little bit of time for questions and answers before Bob wraps things up for us for the day. So hopefully it might be hard to choose. We're attached to all of the chapters of the report, so for us, we envision this being a big dilemma for the afternoon for you, so good luck with that. Now it's time for lunch. There's a cafeteria on the 3rd floor of Keck, if you'd like to check that out. It is an atrium, so it feels outside-ish because there is some natural light. There's also a lot of places in the very close by, couple of block vicinity of the building if you want to step outside and take a little walk and find lunch that way. If you're tight on time coming back, feel free to bring your lunch back with you and finish up during the discussion. We'll keep it very informal. Did I leave any logistics out?
No, thank you very much. We look forward to seeing you after lunch.
Thank you so much. Oh, I'm sorry. There's a map in your packet as well that has some of the lunch locations out and about the building.